my name is Dr. Roopa Mehta. I'm an endocrinologist from Mexico City, and I'm going to talk about obesity and diabetes driving inflammation. So when we talk about inflammation, I'm going to really concentrate on metabolic inflammation. And we know that obesity and type 2 diabetes are associated with chronic activation of the immune system, as well as the metabolic problems associated with them. In both conditions, there is chronic tissue inflammation, and we call this metabolic inflammation. And this is a key feature and is observed in insulin target tissues. So this occurs in both adipose tissue, liver, muscle, and pancreatic islands. And you can see the definition for metabolic inflammation on the right-hand side of the screen. And we generally can detect this possibly by using markers such as high sensitive C-reactive protein or IL-6. And the recruitment and accumulation and activation of pro-inflammatory macrophages in metabolic tissues is a key driver of this chronic low-grade inflammatory state. So let's talk about the origins of metabolic inflammation. So when we think about where does this all begin from, there are several theories. Obviously, multiple genetic and lifestyle factors can contribute to metabolic inflammation. So having a family history of maybe obesity, a poor diet, inactivity can all be factors that can promote this. And it originates from adipose tissue in the setting of obesity, but it can also be shaped by gut microbial rarefication or dysbiosis, host genetics, and also poor diet and inactivity. And as you can see, metabolic inflammation has multiple outcomes, and we'll talk a little bit about this further on. So let's talk a little bit about the gut microbiota generating inflammation. So in a healthy environment, healthy microbiota, these are beneficial bacteria that produce essential metabolites such as short-chain fatty acids, secondary bile acids, and these all support intestinal barrier integrity and help with immune regulation and health. But when we have dysbiosis, this disrupts this balance, and it leads to an increased production of lipopolysaccharides, microbial antigens, and pro-inflammatory cytokines such as TNF-alpha, IL-6, IL-1 beta. This pro-inflammatory response results in damage to the intestinal barrier, immune dysregulation, angiogenesis, and this results in systemic inflammation, increasing the risk of metabolic disorders. So an unhealthy microbiome can produce inflammation. Let's now talk a little bit about adipose tissue. So when we think about adipose tissue, this is just a slide summarizing some of the factors that are released by white adipose tissue. We can have adipokines, cytokines, enzymes, and other factors as well. There's a host of cells in adipose tissue, and we can see the organs that can be affected by the white adipose tissue adipokines. So when we think of adipose tissue, this is really an endocrine and an immune organ. So when we have metabolic inflammation, adipose tissue is one of the prime areas, and this is what happens when we have overnutrition. We have an excess of adipose tissue. Excess adipose tissue results in pathogenic adipose tissue dysfunction. This dysfunction produces systemic inflammation. This results in metabolic dysfunction. And finally, outcomes such as type 2 diabetes, cardiovascular disease, and MASLD. So let's go into a little bit more detail about what actually happens in the adipose tissue. So we know that adipose tissue is a dynamic organ. This responds to alterations in reserves through hypertrophy or hyperplasia of adipose tissue. And on this slide, I'm showing you how we can get differentiation producing either adipose tissue expansion, either via hyperplasia. This is the generation of new small adipocytes. But when we have dysfunctional adipose tissue, it's characterized really by hypertrophy of the pre-existing adipocytes. This increase in adipocyte size is correlated with impaired adipose tissue function. There's increased local inflammation and decreased lipid storage capacity. So these hypertrophic adipocytes, as I've already mentioned, are characterized by hypoxia, fibrosis, pro-inflammatory macrophage infiltration, and a state of chronic inflammation. These adipocytes are less sensitive to insulin, so they don't function adequately and produce cytokines and adipokines, which I'll mention in a moment. And as I've already mentioned, they have a reduced capacity to store fat, so there's a spillover of fatty acids into other tissues, skeletal muscle, liver, and pancreas, damaging cells with lipotoxicity and contributing to ectopic fat deposition and obesity-associated comorbid conditions. So again, in a little bit more detail, we know that the stressed adipocytes secrete pro-inflammatory adipokines and decrease anti-inflammatory adipokines, which I've shown in the blue box in the lower part of this slide. There's chemokine secretion. This attracts monocytes and macrophages, which infiltrate the adipose tissue, and these macrophages undergo a phenotype shift to an M1 pro-inflammatory phenotype, and these macrophages form these crown-like structures around necrotic adipocytes and release cytokines and sustain local and systemic inflammation. And these cytokines I've shown in the pale box on the right-hand side of this slide in the bottom part. So we have TNF-alpha, IL-1 beta, IL-6 in particular, but there are also other inflammatory cells that move in, and they also produce enzymes and can also produce other inflammatory cytokines. And this is really just a summary of showing how the healthy adipocyte can change into a dysfunctional adipocyte, producing these pro-inflammatory adipokines, which produce immune cell infiltration. We have reduced insulin signaling, and we end up with inflammation and insulin resistance. And again, this local and systemic inflammation results in decreased glucose uptake. We have increased glucose production from the liver, so we get insulin resistance in the liver. We also get decreased insulin secretion from the pancreas and beta cell death, and this also affects the heart, increasing cardiometabolic risk. So let's talk a little bit about the adipokines in particular. So the adipokines that are released from the adipose tissue are mediators of this metabolic inflammation. And in health, adipocyte-derived adipokines such as adiponectin and leptin are involved in normal metabolic processes. But when we have obesity, the infiltrating leukocytes become a major source of pro-inflammatory adipokines in the adipose tissue. And it's not just hormones, it's also cytokines. And I mentioned some of these cytokines earlier. TNF-alpha, IL-1 beta activate certain signaling pathways which are detrimental in both adipocytes, hepatocytes, and myocytes. This activation leads to serine phosphorylation of IRS1, impairing insulin signaling, promoting insulin resistance. There's also production of lipid intermediates, which further activate protein kinase C isoforms, enhancing inflammatory signaling and insulin resistance. And remember, the NLRP3 inflammasome is also activated. This is triggered by reactive oxygen species or hyperglycemia, driving further IL-1 beta and IL-18 maturation, amplifying the systemic inflammation. There's also production of exosomes from the adipose tissue macrophages, and these exosomes, as you remember, are a component of secreted extracellular vesicles, and they can contain a number of substances, proteins, lipids, but in particular microRNAs. And these microRNAs that are produced from M1, like adipose tissue macrophages, can negatively interact with insulin signaling. And you can see this in the lower part of this slide. the M1-like adipose tissue macrophages produce, for example, in adipose tissue, more microRNAs of the type 155, which decrease insulin sensitivity, and similar processes in the liver and the pancreatic islet cells as well. So, in summary, when we get this chronic low-grade inflammation, it affects not only the adipose tissue, but also the liver, pancreas, and muscle. In the pancreas, IL-1 beta and oxidative stress accelerate beta cell apoptosis, and we get a loss of insulin signaling capacity, insulin resistance, and possible diabetes. In the liver, Kupffer cells and hepatocytes contribute to the production of mast cell. But as you can see, in general, this systemic inflammation drives atherosclerosis, microvascular damage, and results in cardiometabolic complications. So in summary, metabolic inflammation originates from adipose tissue in the setting of obesity, but it's also shaped by gut microbial dysbiosis, host genetics, and diet and exercise. Obesity, which we find either by itself or even part of diabetes, is characterized by this adipose tissue hypertrophy, hypoxia, inflammation, and dysfunction. Once there's dysfunctional adipose tissue, there's a chronic inflammatory state. This results in ectopic lipid deposition, multi-system inflammation begins, increasing the risk of metabolic diseases. And it's like a vicious cycle. We get chronic inflammation, insulin resistance, metabolic diseases, which drive further inflammation. And finally, for the last few minutes of the talk, I'll just mention some therapeutic approaches for targeting this systemic inflammation. There's been work carried out with IL-1 antagonism, with anakinra, and this has improved beta cell secretory function and reduced glycemia in type 2 diabetes. But we've also had key findings from the CANTOS study with IL-1 beta inhibition, improving cardiovascular outcomes, reducing A1C, reducing heart failure events, prevention of diabetes, cancer. There was a decreased total cancer mortality in this study, and overall safety, but an increased risk of fatal infections. And on the right, I'm showing you some possible targets for future therapies targeting systemic inflammation. And my final slide is really just a summary to show us really what we could possibly do to tackle this inflammation in diabetes and obesity. Obviously, lifestyle changes, including weight loss. We think GLP-1 medicines can have a role. Remember that they acutely reduce biomarkers of inflammation, including CRP, and this is even prior to the achievement of caloric restriction or weight loss, suggesting that they have both direct and indirect anti-inflammatory mechanisms. But remember, medications are also in the pipeline that could target NLRP3, and this kind of inhibition could also target tissue inflammation. So with that, I'll finish. Thank you very much for your attention.
Thank you very much, Dr. Roopa, for this excellent, informative talk on how important is the role of inflammation in driving insulin resistance and all these metabolic consequences. The question is that crosses our mind as practicing physicians. Do you think that we could possibly tackle this inflammatory changes early on before any further, progression to the stage of diabetes or adverse metabolic consequences?
Yes, Nasreen, I think that is really what we should be thinking about, right? We want to prevent this dysfunctional adipose tissue, this ectopic lipid deposition, this chronic systemic inflammation. And one of my slides mentioned the origins, right? And so the origins include obviously genetics, that right now we really can't impact that much. But we saw lifestyle factors. We also saw dysbiosis in the gut microbiome. So I think, having a healthy lifestyle, being active, trying to maintain our weight in a reasonable level can probably be our most important preventive actions. But again, that's very difficult, as we've seen. Obesity is increasing worldwide. Diabetes is increasing worldwide. So I think that's our challenge more than anything else, right? The prevention of these conditions.
Yeah, absolutely. And the fact that we know the relationship between inflammation and the chronic diseases, surprisingly, we don't see that very much emphasized in the guidelines. So what do you think about, guidelines don't routinely recommend measuring inflammatory markers in these patients. So what do you think about that?
So I think the markers we have, I mentioned CRP and IL-6. I mean, CRP we do measure in routine clinical practice, but it seems to be quite non-specific, right? It tells us about general inflammation, which could be due to infection, it could be due to metabolic disease or to immunity, etc. So I think we still need more specific markers possibly. And we're still not really measuring a lot of these adipokines as we should, right? We know that adiponectin levels are reduced in obesity. But again, we really haven't got a good handle of how to interpret these measurements sometimes. So I think we're still in the early steps of these kind of measuring these mediators of inflammation and getting a clear idea of the degree of inflammation, right? And they're not very specific. That's my feeling. I don't know about you. Do you measure anything in particular in your clinical practice?
Absolutely, I agree with you. I mean, apart from the routine inflammatory markers that we measure, such as high sensitivity CRP, again, the practice is very limited, and the access to the all other inflammatory, cytokines is very difficult to measure. But at least measuring the high sensitivity CRP, even though it's not specific, it sort of give you some guidance, even though I agree with you, it's not really very specific. But hopefully we can see more specific cytokines coming in the future. And the role of, the gut microbiota, do you think that what would be the best approach in clinical practice? Would probiotics help in these patients?
Yeah, I think that's it. I think we're still identifying which gut microbiota are healthy and which are unhealthy. And we're trying now with probiotics to improve the gut milieu, so to speak. But again, I still think we don't have enough information, right? And I think we still don't even know which diet is the best in some of our metabolic diseases to reduce inflammation as well. So I think we're still researching this, but it has to be mentioned because I think this is an important factor. And probiotics at least could possibly improve your gut microbiome. But I think generally, prevention, right? We need to maintain our weight, maintain as healthy a diet as we can with all the adequate amounts of macronutrients, and possibly include probiotics, right, to help our gut. But other than that, right now, I think only the CANTOS study has given some idea of how if we tackle specific cytokines and inflammation, we can have benefits. But again, this is the only study so far, and there's a lot of research going on, but a lot of this is still in phase 1 and phase 2. So I think it's watch this space, right?
Right. Thank you very much, Dr. Roopa Mehta, for your excellent talk. We really enjoyed it. Thank you very much.
Thank you, Dr. Alsayed.